Hello, I'm David Nutt. I'm Professor of Neuropsychopharmacology at Imperial College and Chair of Drug Science. And it's a pleasure to be invited to talk to you today at this conference. I'll just get my slides organized. I'm sorry I can't be with you live, but there's a lot going on and I've had a very pressing schedule this week. I'm going to talk to you today about the role drug science has played in moving cannabis, certainly to some extent, cannabidiol forward in Europe. So what is drug science? Well, we're a charity that I set up in 2010. We're not for profit. We are very scientifically led. We have a scientific committee that comprises many of the UK's top academics in the field of drugs and drug use and drug policy. We're completely independent of both governments and of companies. And medical cannabis has been at the heart of our policy thinking over the last 10 years. Our vision is to see a world where drug control is rational and evidence-based, where drug use is better informed, and people who use drugs are understood, where drugs are used to heal, not harm. And of course, that is particularly relevant to the theme of this conference. And our mission is to promote and conduct drug science. And I'm going to show you examples of that in relation to medical cannabis today. Now let's start with this fact that in November 2018, Sally Davis, the Chief Medical Officer, approved cannabis-based medical products. She moved them from Schedule 1 to Schedule 2 and therefore allowed doctors to prescribe them. But as the government gave permission, it also took it away because they set constraints on their use, which have proved to be so intractable that only 3 prescriptions have currently been prescribed on the NHS. And these constrictions were that they could only be prescribed by a specialist. And most specialists are people who've got a research track record who aren't particularly interested in learning about a new medicine, which has been particularly pursued and populated by patients and their relatives rather than by doctors. There's also got to be clear evidence of safety and efficacy, which of course has been challenging with medical cannabis because of the fact it's been banned in most countries in the world for the last 50 years. And because they're unlicensed medicines and because they're Schedule 2 medicines, medical cannabis is only available on a named patient basis. And that makes it extremely difficult, particularly the scheduling, to get the drugs into the country. And current life guidelines also make it very hard. They've basically said it can only be used for children with rare severe forms of epilepsy, adults with nausea and vomiting due to chemotherapy, and that's nabilone and other forms of THC, and adults with muscle pain due to multiple sclerosis, and that's Sativex. And this is truly one of the great failures of medicine in my generation. And I've written a couple of articles in the BMJ about this. It's truly one of the most upsetting experiences in my professional career to see cannabis being so close to being available and yet not being available. And I think this block, which is partly a mixture of poor thinking by the government and also to some extent, I think, a deliberate attempt to not move things forward by the medical profession, is a failure of good medical practice. And in Britain today, we have 1 million people who use medical cannabis, but almost all of them are getting it illegally on the black market. And part of the problem is that doctors are paternalistic. They don't like to be told by patients what they should prescribe. They like to tell patients what to do. And that, in the case of medical cannabis, is the way it isn't. NICE have been intransigent. NICE have only considered RCTs in English. They failed to consider patient-reported outcomes, which is perhaps one of the strongest areas in which where cannabis is shown to be effective. They've shown an over-reliance on company-led registration-style RCTs, and that's been a problem because even when companies have done RCTs, NICE have failed also to accept the pricing. They failed to embrace real medical studies, which is a patient who is given a medicine and the outcome is recorded for that patient. and they've ignored much of the overseas data, which has been collected for the last 10 years in countries like the USA and Canada, where they have big registries. And also the clinical commissioning groups block access because head pharmacists with their budgetary controls often don't understand medical cannabis or don't want to understand. And the failure to allow GPs to prescribe is a huge challenge because the burden of the million patients using medical cannabis is generally being held in primary care, not in secondary specialist care. And we've heard some remarkable things from our leaders in medicine. False fears about cannabis have been generated for decades. And here we have the chief medical officer, who's a doctor in infectious diseases, saying we have to be very cautious about rolling out medical cannabis because we want to avoid another thalidomide scandal. Does he not know that both delta-9 THC and cannabidiol are medicines? They've all passed their toxicity tests. Presumably he doesn't. And then Simon Stevens, the head of the NHS, who isn't the doctor, said medical cannabis is just a route to recreational use. Well, that is actually ridiculous. The recreational market in Britain is saturated, and it's saturated with drugs which are really dangerous, like skunk. And there's a whole another lecture I could give on how prohibition of cannabis has actually made the harms of cannabis much greater. So what is drug science doing? Well, we've done a number of things. We've educated and training doctors to prescribe. We've set up this 2021 initiative I should talk about in a minute. We've written several publications. I've given you 3 examples on previous slides to challenge the ignorance and perceptions. We've supported a legal challenge to NICE for failing to give a balance view, particularly in relation to severe childhood epilepsy. And we've been promoting this vision that Sir Michael Rawlins, the previous head of MHRA, the previous head of NICE, the previous head of the ACMD, said in his 2008 Harveyan oration. And he said, randomized controlled trials, long regarded as the gold standard of evidence, have been put on an undeserved pedestal. Their appearance at the top of hierarchies of evidence is inappropriate. And hierarchies themselves are illusory tools for assessing evidence. They should be replaced by a diversity of approaches that involve analyzing the totality of the evidence base. It is absolutely clear that the majority of the profession, both pharmacy and medical profession in Britain, is actively avoiding doing that for medical cannabis. And here's an example of that avoidance. This is an analysis that one of my PhD students, Ryan Zafar, did of 10 patients who have severe epilepsies. They have all failed on multiple anti-epilepsy drugs. They've all failed on Epidiolex. Some of them have had surgery for their epilepsy, which has not worked. And they're all doing well on Bedrocan or Bedrocan products. And what he did was he did an audit of the seizure frequencies before in light blue and after in dark blue of their, before and after they started on their medical cannabis. Now you can see that the blue bars are lower than the light blue bars. So after the cannabis, they have fewer seizures. These 2 didn't have any seizures, they were cured. And overall, the reduction in seizure frequency is 50-fold. And if you look at the mean reduction in each patient, overall, there's an 83% reduction in seizure frequency. So this is enormously powerful. This is a log scale, by the way, in case you're wondering why the numbers are so high. So the parents are telling us this medicine is basically radically improving their child's health. But only one of these children is getting the prescription on the NHS because pediatricians refuse to believe these data. Now, analysis using Bayesian statistics shows that the next child that goes into this cohort with the same kind of treatment-resistant childhood epilepsy is at a 92% chance of responding. That is better than any clinical trial that outcome that you could predict. So this is, I think, a failure of medical leadership to understand the value of this kind of case control study. And meanwhile, whilst they're not getting prescribed on the NHS, the families are paying for this. They're paying on average £1,700 a month for this medicine to keep their child alive, give them a quality of life. Some of them have sold their homes just to be able to pay this. Some of them have not been able to, and the children have slipped back into more severe epilepsy because of this. One of the things drug science has been doing is trying to get the price of medical cannabis down, and I'll talk about that under 2021. We've managed now to get, for most of these children, if they want it, down to about £300 to £450 a month, which is a considerable saving for them. And we've done it in the guise of this project 2021. So what is this? Well, it's the UK's biggest national medical cannabis real-world registry. It's a multi-stakeholder partnership with academics, industry, clinicians, and patients. It's the largest body of evidence collected in a systematic way for both effectiveness and tolerability of medical cannabis. We're going to publish the data regardless of whether it's favorable or not. It's going to be a fully accessible database. And we're anticipating, and this is where the 20 comes from, 20,000 patients can access this with the project. The 20,000 comes from the number of patients who are in the medical cannabis charities at the time we set this up. So who are these stakeholders? Well, we have drug science experts. We have database registry experts. We have clinicians and prescribers. We have patients, and we have licensed producers. And the licensed producers come from all around the globe. In order to make this as informative and as respected academically as possible, we've created a scientific oversight board that covers the fields in which the medical cannabis is being prescribed by experts. So each of the particular topics, which I'll talk about in a minute, the diagnosis, is headed up by an academic expert. Overall, Professor Mike Barnes is one of the great, as you know, the great pioneers of medical cannabis in Britain, and he's chair of our scientific oversight board. I have been a campaigner and a researcher in the field of cannabis for decades. I'm a neuropsychopharmacologist, particularly interested in PTSD and anxiety disorders. Professor Eileen Joyce at Queen Square is interested in and heads up the Tourette's data collection. Val Curran is a leading clinical psychopharmacologist at UCL. She's very interested in the whole question of whether people who use medical cannabis become dependent on it. Adam Winstock runs a global drug survey and is also an addiction medicine specialist. Adam Fias at UCL is a pain expert. Elizabeth Iverson is a stroke physician and a prescriber. Tim Williams, a psychiatrist. And Michael Linsky is an epidemiologist, and he looks after the data. So that's the scientific advisory board. What about the indications? Well, these are the indications you see here. For each indication, our experts have defined the right kind of simple questionnaire to monitor outcome. So for pain, it's a brief pain inventory. For anxiety, it's a GAD-7, et cetera, et cetera, et cetera. But for every single patient, we measure aspects of their quality of life and their health using validated measures such as the EQ, quality of life, the European Quality of Life 5D, the PHQ-9 for mood, and also we measure sleep. Because we know that patients are telling us that the real value of medical cannabis is that it improves their quality of life in a way which traditional medications don't. So everyone who comes in has their demographic data taken, the diagnosis and comorbid conditions assessed. They have to give us access to their medical files and their GPs. They have to have failed at least 2 previous treatments. And we're monitoring not only outcomes, but also adverse events. So the patient access was facilitated initially by the United Patients Alliance and now by PLE, Patient-Led Engagement for Access, and some of the other patient support groups. These are the disorders I've already mentioned. To get into the study, you've got to have these, and we're all now in the process of bringing in epilepsy, adult epilepsy as well. What about the cost of medication? One of the great achievements of drug science in this initiative has been to persuade companies that it's in their interest to subsidize this access to medicine. So basically, we have brought down the price of treatments of a particular therapy to £150 a month. And the reason for that, as pricing at £150 a month, is that on average what people are paying on the black market. So if they're prepared to pay that in the black market, they should be prepared to pay that in 2021 and guarantee quality and reliable and safe, well-prepared medication. So you can have THC, you can have CBD, or you can have flower. We're very interested in using the latest technology to garner information in relation to patients' progress. So we're working with Altaflora, one of our partner companies, who've developed an app that allows us to, on a daily or hourly or whatever basis we like, collect data on symptoms, severity, etc., etc. So this will add quite a lot of novel data to our outcomes. Products, they come from all over the world: Australia, Life Group in Britain, Celon in Switzerland, Chiron in Colombia, and the Jamaica Medical Cannabis Group in Jamaica. So these are all working together to support this initiative. And the overarching purpose of 2021 is to collect real-world data, the kind of data that actually matters most to patients. Patients don't care about RCTs, they want to know how well they are going to do. So, as I've said, we collect demographics, medical history from the medical records. We're collecting patient-reported outcomes using those diagnostic scales at baseline and at 3 monthly intervals. We're doing statistical analysis of the longitudinal data, and we've got regression and latent trajectory programs to impute missing data, etc. Drug science retains control over data analysis and release. The companies do not have any ability to stop us publishing what we want. They don't have access to the data in any way except for measures of adverse effects when they need to report to the MHRA their annual updates of adverse effects. And this emphasizes the value of this approach. This is the actual Harveyan oration by Sir Michael Rawlins, and it's kind of worrying, really, that this is 12 years ago. The head of NICE recommended we completely revise our approach to assessing the evidence of medicines, and yet NICE and the medical profession has completely, it seems to me, ignored this. So we're trying to put this back at the front of evidence gathering for medical cannabis. And here are some of the points from that Rawlins paper. The first is there are conditions where it's impossible to do RCTs. Treatments for very rare diseases, where the number of patients is too limited. Some of our children with severe epilepsy, there's only one of them in the country. You can't do an RCT on one child. Some of them don't even have diagnoses. We don't know what syndrome they've got. You can't do a traditional study on children with an undiagnosable epilepsy. Sometimes it's unnecessary when treatments produce dramatic benefits. And he gives the example of imatinib for chronic myeloid leukemia. We've got evidence from and she showed you, people in our children going from 3,000 seizures a month to 0 seizures. That you don't need statistics to show that this is a powerful medication. Another very interesting area is Ehlers-Danlos syndrome, where we have a number of patients with this syndrome, which has, I don't think, ever been put through a clinical trial for anything, doing dramatically well. If they shouldn't be expected to wait possibly forever for a drug company to do a trial. If they have a right to try out the medicine on themselves, and if it works, they have a right to access it at a sensible price. RCTs are very resource intensive, on average 3 million up to 100 million. They give you an enormously expensive way of gathering relatively poor, ungeneralizable data. And the reason they're ungeneralizable is because the patients who go into RCTs are patients that don't have other disorders. And yet the majority of people, as you'll see from the upcoming slides, in 2021 have multiple comorbidity. So they never be put into an RCT. There's no reason to suppose that an RCT is going to have any particular bearing on them. And certainly they shouldn't be forced to wait for an RCT before they can have an experimental trial of medical cannabis. But there are challenges. Real-world data, you often have more missing data. The data you have is not necessarily as intensively collected as you have in RCTs. We don't put as much resources in. We don't have the resources to collect data in the same intense way as in RCTs, but we don't want to waste money on doing that. And we can potentially use artificial intelligence, etc., to begin to improve the data. But these challenges are outweighed by the huge advantages. We get large samples. I'll show you. We've already got 600 odd people through G21. We've got a range of products. Doctors prescribe according to outcomes, so you can titrate to optimal benefit. And they represent the complexity. These patients are very complex. The multimorbidity of our patients is enormous. So here's, I'll just say the Department of Health a couple of weeks ago asked for a report on 2021. We didn't know why. They haven't told us what they've done with it, but this is what we gave them. So by the 26th of February, we've had 8,363 registered on the website, 874, 611 patients have contributed. The majority were male, average age was 40, 39.8. So here you see, the first thing to say is that this is not a group of young people who might want to be using cannabis recreationally. It's a group of people who are at their working age. Primary conditions, pain, about 60%, anxiety, about 30%, and then other disorders, multiple sclerosis, PTSD, Tourette's, epilepsy. And this is the point I was emphasizing earlier. Multimorbidity is extremely common. So here are the number of people with secondary conditions. 1, 2, 3, 4, 5, 6 to 9. So the vast majority of people have multiple conditions, which would potentially exclude them from a normal RCT. And these are the conditions: stress, 29%, insomnia, 30%, depression, 42%, back and neck problems, 32%, anxiety, 30%. So these people are very disabled, and you'll see from the next score that their quality of life is very, very impaired by their disorders. So this is the EQUAL 5D, and the mean of our patient groups is 47. 100 is the best imaginable, and the mean for UK households is 86. So our patients have almost half the quality of life of the average person in Britain. And that is why they need help. And that is why they're coming to T21. And that is why it's outrageous that they cannot have access in a normal fashion to a medicine that we think will help them. Here's the depression scores. Only 9% don't have depression. 27% have severe depression. If you go back to the normative data for this scale, PHQ-9, in depression, high depression scores in the general population in Germany, about 1.3%. So we have a population that is scarred by mental health. What about sleep? 59% report their sleep patterns interfere with their daily activities. 40% severe problems in falling asleep. 34% severe problems in waking up. And 39% severe problems in staying asleep. So they've got gross impairments of sleep. And we know that sleep impairment reduces life expectancy, increases morbidity of many disorders, accelerates neuroinflammatory disorders, and of course, is a major factor in depression and anxiety. What are the products that are getting prescribed? So let me explain the prescriptions. The doctors who are part of this program are all private doctors. They prescribe according to their knowledge, according to the list of prescribable medications, which come in at the price of £150 per medication per month. And so they choose based on the patient's diagnosis and what they think is the best evidence of particular products. So you're seeing that about 32% are getting high CBD oil, about 20% are getting balanced CBD THC oil or flower, and about 3% are getting high THC oil, and about 25% are getting high THC flower. And this is usually used on a vaping basis to alleviate acute episodes of severe pain. So what we have in the first set of 3-month data, and the later data is going to be published in the next couple of weeks in the journal called Psychopharmacology. But what we've seen from the EQ5 is the quality of life has gone from 41 to 63, a 50% increase in the quality of life. And I can say, I'm a psychiatrist. I've been working in the field of depression and anxiety treatments for pushing 40 years. I know that all the drug companies that have medicines in this field, particularly the antidepressants, have been desperate to show an increase in the quality of life with these drugs, and they've generally failed. the fact that medical cannabis is producing a profound 50% increase is enormously reassuring. And it essentially tells us that the patients who are using this are doing it because it does really help them. So this is hugely significant. Sorry, I've just done this already. Apologies for adding these. Here's the quality of life measure. And here's the depression scores. Here's the sleep. Here's the prescribed products. What about safety? Well, one of the key aspects of Project 2021 is monitoring safety. So we're collecting information on side effects for every specific prescription, including data on negative as well as positive side effects. And at present, there have been no serious adverse effects and no yellow cards have been submitted. And we can therefore conclude that 2021 is delivering very powerful benefits in terms of quality of life. We will begin to analyze the symptom changes when we get slightly more numbers. Medical cannabis, as prescribed in this way, seems to be very safe without serious adverse effects. And we are very pleased that we've put so much effort into 2021 because I believe it could revolutionize the understanding of the value of medical cannabis in Britain and hopefully empower doctors who are currently not sure about medical cannabis, give them confidence to go on our training courses, learn how to use it, and then become prescribers. Thank you very much.